Welcome back, everybody. This is John Malanca with the Association of Cannabinoid Specialists. I'm your host, John Malanca. We have Sandra Carrillo, we have Suraj Tandon, and Dr. Adam Abodeely, all doctors, my apology, and Dr. Jordan Tishler, the head of this organization. So welcome, always great to see you, and thank you for our audience. This topic, actually, thank you for writing in. So if anybody wants a topic for us to cover, please do. This is why we do these for you, our audience. The topic is cardiovascular health and how cannabinoids benefit or hurt the. I don't want to be the site that always says cannabis is good. We all know it's not for everyone. So, Jordan, if you want to take this top question here, the benefits or the negatives of cannabinoids with patients suffering with cardiovascular issues.
Well, I don't want to be the wet blanket, but I'm not sure that I can think of much in the positive category, actually, at least that's based on science at the moment. I think that when we think about the cardiovascular effects of cannabinoids, and at this point, we're really pretty much talking about THC, there are kind of wide range of effects that we have to consider sort of from the relatively banal on up to the more serious. In almost all of our patients, we're going to see some transient dip in their blood pressure when they first take the cannabis. And the result of that can be some lightheadedness, but more commonly sort of racing heartbeat. And sometimes people will find that very distressing. Other patients will mistake the racing of their heart for sort of a panic attack. And then that can sort of cycle into an actual panic attack. So we think that, for a lot of our patients, we need to warn them about this so that it doesn't happen, or that they recognize that that's just kind of a normal effect. And then we can start to talk about, what do we do or what do we know about the effects on the cardiovascular system for patients who have cardiovascular disease, particularly either coronary artery disease or congestive heart failure. And those are areas where the THC can come into play in a negative fashion. I certainly could wax poetic about it, but I want to let my colleagues have a crack at this question as well.
Dr. Tandon, would you like to follow up on this one, please?
Yeah, no, I think I second Dr. Tishler's comments about the evidence and the data and the caution, including the relative amount of positivity in regards to cannabis use, particularly in cardiovascular patients. I think the evidence that we have, first of all, is quite limited, but mainly focused within animal models and observational studies, particularly in chronic inhaled cannabis users. Much of it, again, is using products that have high levels of THC. When we look at cannabis, we need to think broadly in the sense that it's not just THC, it's not just CBD, but many other types of cannabinoids. And I think the jury is still out in terms of what the potential positive effects of other types of cannabinoids may have on cardiovascular patients. But with that being said, I think we do have certainly evidence within animal models, even at a molecular level, showing that the use of cannabinoids, particularly THC, can propagate or increase the risk of cardiovascular disease in patients who have existing or pre-existing risk factors or known disease. Those are, that evidence is certainly out there. I think what we need to do is further look at that in greater detail. But we do know that, the activation of certain types of receptors, mainly CB1 and CB2 receptors, these receptors, again, are found throughout the body, mainly the cardiovascular system, the central nervous system, the peripheral system as well. And when these receptors are activated with cannabinoids like THC, they can have direct and indirect effects in terms of plaque development, heart rate, or, in terms of what we're saying, the pulse going up, changes in blood pressure, the formation of these plaques that can lead to worsening disease or symptoms. And it's not just in terms of cardiovascular disease patients, but patients who either have recent, cerebrovascular events such as strokes or TIAs. And also, I think we need to be mindful of the evidence where there is known drug-drug interactions. And I think, I'm sure we'll talk about that today, is cannabis and its interaction with various types of cardioprotective medications like warfarin, calcium channel blockers, antiplatelets, et cetera. So I'll let my other colleagues chime in as well.
Let me jump in before we pass it to Dr. Abodeely and Dr. Carrillo. A lot of the studies that I have seen out there have to do with inhalation via smoking, and I know you mentioned that, Suraj. Are you seeing different or lower risks when it comes to heart rate dilating, blood vessels, et cetera, by ingestion via tincture or oil or edibles?
Yeah, so good question. I think what it comes down to is whether it's inhalation or ingestibles, oils or capsules. In my own patient population, is that patients who are using a certain percentage of THC can have the same risk, the same symptoms, whether they're using it via inhalation or by ingestion. With other types of cannabinoids, and this is where it really requires us to have more robust research and higher quality evidence to ascertain, to see whether CBD or other types of cannabinoids create the same effect or the same negative effects. That's something that's still yet to be determined. But with that being said, most of the patients who are either using cannabis, particularly high THC or low levels of THC, can develop those symptoms. But there's a way to mitigate those risks, and I say this by working with a health practitioner who is well experienced in these potential drug-drug interactions or known pre-existing disease, where it's very important to dose titrate in a safe manner.
Oh, yeah.
Thank you for that.
Amen.
And Dr. Carrillo, benefits. I've worked with many doctors and patients that have found benefits in not via smoking, but other types of ingestion, where it is lowering their blood pressure, and it also, I guess, reducing the risk of hypertension for heart disease. Are you seeing that in your practice? Is it something that you would recommend to your patients of different ages? And I know, as Suraj was mentioning, it's not a one-size-fits-all. Drug-to-drug interactions do take place, as well as sensitivity. So if you can comment on that, please.
Exactly. Well, definitely we have different types of evidence, and in the clinical practice, as Suraj and Jordan mentioned, this is like a very personalized medicine. So we have to assess the other comorbidities, the other medications the patient is taking, and it's important to know the short-term consumption can cause like euphoria, sometimes tachycardia, and even in 2020, the American Heart Association released a statement warning about the risks or benefits about the use of cannabis, particularly, as Jordan says, THC is the one that we have to watch or monitor. In my private practice, I usually I'm very careful with patients. They have unstable cardiovascular pathologies, because we know that high amounts of THC can maybe particularly predispose these patients that already have arrhythmias or atrial fibrillation to have a bad outcome. So it's very important to be cautious and have a very complete clinical record with the patients and see if he has history of arrhythmias or atrial fibrillation in order to make a decision. And definitely all these warning signs that the American Heart Association was putting out, it was also due to the increase of the concentrations of THC that people is using, and definitely it is more in the context of the adult use or recreational use. In the medical, when we're using it under prescription, since we do titration, a proper titration, we can avoid that these things happen to the patient, and we are weighing risks versus benefits. So definitely, I think the key will be in assessing the comorbidities, the drug-drug interactions, and personalizing the patient, definitely, and with the different types of cannabinoids, definitely be careful with the THC, because in the elderly population, sometimes I see they can have hypertension. So you can avoid all these by doing a proper titration, and as we always say, go slow, start slow, so you can monitorize that the patient don't have like side effects that they are not desirable for the patient, and we can have like better outcomes.
Yeah. And actually, I was waiting this next question here for our board certified surgeon, Dr. Abodeely. Please, I mean, this must be something that you ask your patients in an intake form before going into surgery. Can you share some of your daily experiences?
Sure. Well, first, I agree with really all the comments that were made by the other participants here. And when I think about cannabis in the context of cardiovascular risk, I think about it the same way we approach risk when we're evaluating somebody for surgery. And another comment that I will make is that, again, being a surgeon, I also am not don't claim to be a medical internist and has that experience and that knowledge of how the cardiovascular system works as well as I might like, or some of my colleagues do. But certainly, whether it's me seeing a patient for medical cannabis or it's one of my nurse practitioners, there are some things that are meant to initiate a more robust discussion around the use of cannabis, and one of them is being cardiovascular risk. And so, if somebody has a cardiovascular risk, we have to be more mindful of talking with them about some of these transient effects. Now, I'll make a few comments around some of these transient effects, and I've had these discussions with I practice in a relatively small area. I've got just a handful of cardiologists, and I've had these discussions with them because certainly I don't want to be I don't want to risk my surgical credibility based upon me having somebody have a bad cardiovascular outcome from using cannabis. So the point being with that is that whenever I have any questions, I certainly I reach out to my cardiologist colleagues and run cases by them from time to time. At least, and this has been an educational endeavor as well. Initially, anybody with any cardiovascular risk, we simply didn't recommend cannabis, but now we've become certainly more selective about it. And some of the things we talk about are the transient drop in blood pressure, which as we know causes increased cardiac output and might put a little more stress on the heart. I do talk to them about the fact that this tends to be mitigated over with chronic use. We don't see as transient drops, but we do talk about ways that we might potentially minimize these side effects. And particularly if they're first-time consumers, the whole rule of start low and go slow, I think, certainly applies. But also the first time that they do consume, we certainly recommend that they not be going out, getting behind the wheel of a car, not be out driving, not be out doing activities the first few times, be sit comfortably in your chair and get up slowly. The other thing is, it was discussed about forms of ingestion. And although I can't say with any confidence one way or the other, I do tend to discourage anybody with high cardiovascular risk from smoking for just the negative effects of combustion on the lungs, but also because of the more acute, the higher levels of THC that enter the bloodstream can have more of potentially have more of a transient effect early on. So, starting somebody out on an edible, if someone with a high cardiovascular risk comes in looking for cannabis, say for chronic pain, not for cardiovascular reasons, but for chronic pain, then in these cases, I tend to steer them more towards an edible, starting with really low milligrams of THC. Now, again, this is a personal practice preference more than anything else. Just one of the ways that I try to potentially minimize, some of the cardiovascular risks. I don't think there are many things we can do. I do think that the cardiovascular risks are real, but I also think that it's not quite, it's similar to a lot of the other negative things that people like to talk about with cannabis and the medication. But, a lot of medications can lower your blood pressure. Antihistamines can lower your blood pressure. All the sorts of these things do. But given the fact that cannabis is, still being, under the microscope, and there's a lot of critics that, anything we can do to minimize the potential cardiovascular risks, I try to adhere to that.
You mentioned about low dose, and I know this comes up quite a bit. Sandra was talking about start low, go slow, which we've heard for years in this industry, probably in a lot of industries as well. But what would you consider? Are you looking? I know what I consider as low as anything under 5 milligrams. Patients, and I know Jordan and I have spoken about this and had discussion. Are you seeing success at 1 to 3 milligrams, or would you share with not only our medical professionals listening as well as the patients that are listening, what would you consider a safe dose as a starting point, not only for I'm a senior citizen now. I'm 56. I was in a senior center the other day. It says computers reserved for senior citizens only. I said, you gotta be kidding me. So for us seniors, what would you start? And you in the youth, you guys and the seniors like myself, what is a safe dose? A starting dose, actually, if they know nothing about it. And for the medical professionals that are coming to the Association of Cannabinoid Specialists to learn about this, can any one of you, share what you feel is a nice starting point? And again, we know it's not a one size fits all.
I was just actually looking at this and writing about it because, as you may know, the association is putting together a CME course aimed at the various state requirements. So we're putting together this prop package, and the starting dose is actually a little bit of a feel thing. I mean, on average, I would say I start my patients at 5 milligrams, but then there are the patients who, for one reason or another, I might start them at half of that, right? And those reasons are not concrete, right? They're things like the patient has cardiovascular disease, or the patient has a lot of anxiety about cannabis, right? Or the patient says, oh, I always get a very brisk reaction to all medicines. Which sort of defies the physiology. But the point is, whether it's physiologic or it's psychological, the point is some people are sensitive to medicines. And so at that point, I might say, all right, take half a gummy, right? 2.5 milligrams. A lot of that's a feel thing, and you just try not to overshoot the mark, because the worst possible outcome is that they have a panic attack or something like that. And then, you might very well be able to get them to a point of benefit down the line. But if they've lost faith in your ability to guide them, then it isn't going to happen. I wanted to take a moment to talk a little bit about some of the data that we have. There have been a whole bunch of studies that have looked at the effect on cardiovascular systems sort of at the epidemiologic or population level. And none of these studies are very good, in the sense that they're not well controlled. They're typically what we call a retrospective chart biopsy, meaning that they're looking at medical records rather than at the patient outcomes per se, which means that the information that is available is only as good as what was written in the medical record. All that being said, there seems to be a roughly 20% increase in MI, heart attack, across the population in cannabis users versus non-users. I think that some of that can be explained by people who have existing coronary disease, so their coronary arteries are narrowed with gunk, for lack of a better word. We call them plaque. And so when that heart rate goes up that we've talked about, then the demand from squeezing hard can outstrip the ability of the blood to flow through the coronary arteries and supply the heart. Then there's some literature of heart attacks in young people, meaning, the 20 to 30-year-olds who presumably don't have underlying coronary artery disease yet. And it's really unclear what to make of that. There's also a lot of data that cannabis, and THC in particular, is what's called a negative ionotrope, meaning that it actually not only can make your heart squeeze faster, but less forcefully. And so, in fact, the movement of blood can be diminished. And this doesn't matter to the 5 of us as individuals. but people who have heart disease where they've lost heart muscle through previous heart attacks can have this condition called congestive heart failure, which can be compensated, meaning they're doing just fine. But if you push them, if you upset the biological apple cart with something like the THC, then they can develop poor blood flow and shortness of breath and stuff like that. And that seems to have about another 20% risk associated with it. And Dr. Carrillo mentioned atrial fibrillation. There seems to be, again, another relative risk of about 20% of provoking atrial fibrillation. Most people who have atrial fibrillation are already anticoagulated, so that's not such a big risk. But there are going to be occasions when the incidence of the cannabis use corresponds with new onset atrial fibrillation, and that needs to be picked up so that people aren't walking around untreated for that. So overall, kind of my take is that if people have known heart disease, they have angina, they get chest pain when they exert themselves, if they have underlying CHF, these need to be taken seriously. And I tell all of my patients, look, if you get pain in the chest, you get short of breath, those sorts of things, don't just assume that it's the weed. Call 911, go into the hospital and let them take a look at you. Because the last thing we want you to do is sitting home, watching the television and having a heart attack, right? So anyway, those are my
Jordan, do you happen to know what those studies, if they controlled for confounding variables, or how well they did that? Because that's the question that always comes up is, is it really cannabis causing this? I mean, because the person who's at risk for cardiovascular disease is also the person that's more likely to, have a poorly controlled diet and maybe smoke cigarettes and, drink alcohol more they should. So
I think that that's exactly the right question. And the answer to that is yes, they did control for those things, but their ability to control for them in the particular design of the study is somewhat limited. So they basically are taking, a cannabis user and a non-cannabis user that have sort of very similar other background demographics, whether it's age, gender, known heart disease, tobacco smoking, et cetera, all those things that you mentioned, and they're trying to pair them up and see who did better. There are valuable insights in those kinds of studies, but there are also limitations. And so I think that we have to view the outcomes of those studies with some hesitation. On the other hand, the study design that would be better would be a randomized controlled trial, and there's no way you're going to do that, right? To study, this on a population level. So, so I think we're sort of stuck with trying to infer from these less airtight types of studies something that guides our management. And perhaps over time, we'll start to see some better designed retrospective studies, or maybe some case-controlled prospective studies. That really comes down to who wants to pay for it. Hello, NIH, pay for it, please. But yeah, that's, I think, where we are.
I'd like to make two comments there to piggyback on both Jordan and Adam's. I agree. I think there are too many variables to control for. When we look at the studies that have been done, the types of cannabis products that have been used, in what formulation, how they've been regulated, tested, what percentage of THC, there's too many variables. And again, there are many unregulated cannabis products in which people are using that may have other adulterants within them as well that could increase the risk of these cardiovascular symptoms, right? We know that inhaled cannabis, many if it's being, let's say, being grown by a dispensary, they're using various types of pesticides. Just the mere use of it by combustion can produce all these other harmful toxins that could stimulate, these negative cardiovascular outcomes. With that being said, I think what it's important is, even just to all of us, for anyone who's listening, is just to be mindful that as much as we're talking about cannabis, and I think most of the talk is kind of negatively harping on THC, there are other types of cannabinoids that that do have medical utility, but we need higher quality evidence. And I think it comes down to, when selecting or deciding, I think my second point is, when considering cannabis for medical purposes, I think the first thing for any providers that are listening or for patients is to just, speak with your doctor about it, openly have a discussion to see if this is something that could be incorporated in your care. What are the risks? Make sure you disclose if you do have any cardiovascular disease risks or pre-existing disease history. Make sure that's known. If you're on any particular drugs that are cardioprotective, make sure that's known, because there is evidence that cannabis and these substances can interact with each other and affect the efficacy of those drugs. So I'd say first thing is to have an open discourse about it, to make sure known disease has been discussed with your doctor. But also, I think what it comes down to is, if we have to selectively choose a type of cannabinoid for your ailment, it really varies in, whichever region you're in. I know many of us, you guys are in the US, I'm here in Canada, and Sandra's within Latin America. Access to various types of cannabinoid products, how they're regulated, tested, the concentration of cannabinoids varies from country to country. To John's comment about what's the effective dose, or what is the dose that people prescribe, or what's the lowest dose. I think this is the art of medicine. This is the beauty of it, is that we're all going to have some degree of varying opinion, but for the most part, our goals are to incorporate products like this with a safe mind, that we're ensuring that if we're going to consider a product, that we're ensuring that the product is safe with you and your known condition or whatever disease that you have. But my word of caution to any patients listening or any providers is that speak with your patient, accept their questions about cannabis. If you don't know, then reach out to expert practitioners in medical cannabis, whether it's through ACS or through your local community. But the main thing is to be informed first, educated, and seek guidance amongst other specialists.
Yeah, I'd like to add to that, it is not being a one size fits all. Just because it works on your friend, family member, and with the same ailment, same age, everything, doesn't mean it's the right formulation for you. So as Dr. Tandon was mentioning, medical professionals should be involved. Let's talk, especially with the senior sector. Senior sector in this industry is the fastest growing sector, and it's coming from the reefer madness era, say no to drugs. And now they've actually changed that mindset to saying, hey, this is helping me get off my other medications. And so speak for your medical professional. If they don't know about the endocannabinoid system or confidently recommending, please reach out to any of these fine doctors or the Association of Cannabinoid Specialists. Before we go, I know we have a lot of medical professionals that listen to us, but we also have a lot of patients that follow us as well. So would any of you like to finalize this with how to improve heart health? Talking about smoking, alcohol intake, and so eating healthy, being active. Can you add to that list that we can help preventative? Yeah, exercise, eat healthy, be active, exercise, weight, lose weight, control your cholesterol and blood pressure, another thing, and manage stress. That's another topic that we'll cover, managing stress, which comes up quite a bit. Sleep, pain, stress are other major topics about how cannabis can help. So would any of you like to finish this?
Well, I just want to, go ahead, Adam.
No, I think one thing that's just worth a discussion and get people's opinion in this group too is, we've been talking about cannabis, but given the fact, I know Suraj, you talked about what do we think about CBD, and when it comes to cardiovascular risk. Bottom line is there's still people that are consuming it and for reasons that are supported by medicine, and a lot that aren't. But regardless, we're not going to be able to stop that wave of people consuming CBD, but it's certainly worth, I think, discussing. My understanding of it is that, from preclinical studies, we do have some evidence that it can affect blood pressure and heart rate similar ways that THC can. However, in the limited human studies that we do have, even higher doses haven't been shown to affect that. Now, I can't comment specifically on, cardiovascular risks associated with CBD, cite any particular studies, but as it relates to the studies that I am aware of, even these higher doses of CBD have not been shown to be associated with changes in heart rate or blood pressure.
I think the biggest issue in my mind around CBD is actually what Suraj was talking about earlier, which is that of all of the cannabinoids, it's the one that interacts with other drugs the most, right? And the list that are particularly cardiac specific are long. So he mentioned warfarin, which is an anticoagulant, also clopidogrel or Plavix, which is a different kind of anticoagulant, but things like amiodarone, which is a heart rate control medication. There's just quite a list of them. And so again, you know, as you said, a lot of people out there using CBD without professional guidance. I think that there's a significant risk to them from, you know, using CBD with these medications with which it will interact, and just not knowing that, and potentially getting themselves into trouble. The other thing I wanted to point out, and this is something that's come up for me a bunch of times, is that occasionally I'll get somebody who comes in and they have terrible, horrible cardiac disease, you know, class 3 heart failure, where I'm really not sure whether I'm going to be doing them any favors or not. And in that instance, generally speaking, what I do is I reach out to their cardiologist, right? Say to them, you know, the patient has come to me, and the other thing is like, what are they coming for? They're coming for, you know, horrible back pain, for example, right? And generally speaking, the cardiologist have responded to me over the years and said, yeah, you know what, this does pose some risk. You're going to watch him. I'm going to watch him, but he's so miserable from his back pain that anything we can do to benefit his pain is worth trying while we have him under our watchful eye. And I think that that's the most collegial and medically responsible approach that you can take.
This has been an informative topic. We've covered a lot with this. And so for our listeners, please follow us for topics like these and many more, and write into us. Dr. Tishler is I guess the leader of the Association of Cannabinoid Specialists. If you want to give it a plug of what we do here and how it benefits.
Sure. The ACS, Association of Cannabinoid Specialists, is an international not-for-profit of clinicians. We're focused on providing education that is human evidence supported to clinicians so that we can all work from the same playbook. And we also spend a fair amount of time on advocacy so that we can see regulation and legal and laws change that are better supportive of our patients. And you can learn more about us at cannaspecialists.org. Again, that's cannaspecialists.org, where we have lots of information that's available, and we welcome you to become members. We have a whole bunch of resources available to you. You can read about them on our website.
And what about medical students coming in?
Oh, yes, medical students. Actually, any kind of a student, not just medical students, can join for free. And we have special activities and groups that are aimed specifically at students. So thank you for reminding me.
Perfect. Well, Dr. Sandra Carrillo, Dr. Suraj Tandon, and Dr. Adam Abodeely, and Dr. Jordan Tishler, I thank you again for another Casual Conversations. And John Malanca, your host, and we will see you next time. Have a wonderful day, everyone. Thank you.